Good afternoon, everyone. We'll go ahead and get started. My name is Mark Hughes. I'm co-chair of the Ethics Committee here at the hospital, and welcome you to the May installment of Ethics for Lunch. This is a monthly series where we are sponsored both by the Berman Institute of Bioethics as well as the Johns Hopkins Hospital Ethics Committee and Consultation Service. On your handouts, you can see a little more information about both the Berman Institute and the Ethics Committee and what they're trying to achieve. The Ethics for Lunch is a forum where we really want to try to engage with the clinical community and the larger community about key ethical issues, especially as they pertain to clinical ethics. So we appreciate that you've all come, and we'll hear about an interesting topic today, claims of conscience. There's a little blurb about a particular case, but this is an issue that sort of has wide-ranging ramifications for a lot of clinicians in thinking about their own morality and their own conscience of how they address health issues. Our moderator for today is going to be Dr. Cinda Rushton. She is a professor in the School of Nursing, a core faculty member in the Berman Institute of Bioethics, and also co-chair of the Ethics Committee. So I'll turn it over to Cinda to introduce our panel.
Thank you, Mark. Welcome, everyone. I'm going to introduce our panel, and then I'm going to give a little bit of a context for our discussion today. We have a great panel. Ty Crow, who is our Director of Spiritual Care here at Johns Hopkins Hospital, also an Ethics Committee member. Gail Viva, who is the nurse manager in the Neuro Intensive Care Unit and an incredible leader in our organization. Janine Althouse, who is OB extraordinaire, also a part of our ethics service and does maternal fetal medicine and outreach. And Carol Symes, who is our community representative on our ethics service and has taught me a lot in our many years of working together. So I wanted to start by thinking about what conscience is, so that we can kind of get a sense of what the territory we're talking about. So often we think of conscience as a kind of barometer, and if you think about your own experience, often conscience is activated in our bodies. So often we notice there's something that is directing our attention in some way or another. But it's a way to appraise our intentions, our acts, and behaviors is either morally praiseworthy or morally culpable in relation to some moral ideal or standard. So it's that sense of assessing whether or not we're acting in alignment with our values or not. And it involves often a reflective process. And some of the questions we might be asking ourselves is what is obligatory, what is prohibited, what aligns, actions or behaviors align with our sense of good or bad, that kind of appraisal. What is virtuous, honorable, what might be malicious or hurtful. And as a part of this process, there's often this attention to the feelings that we associate with this kind of appraisal. And most of us know that feeling of, we know we've sort of gotten off track, and we can often feel it very much in our bodies. If we're in alignment, then we often feel balanced and at peace. Often there's a sense of feeling resolute in what we need to do. And when we violate our integrity, there's often feelings of shame or guilt or remorse associated with those actions. So it's important to kind of think about where conscience comes from, and to think about, well, how do we respond to those situations that activate our conscience in action or inaction. So when we talk about conflicts of conscience, we're talking about two conflicting moral demands or obligations. And many of us have so many experiences where there are two things that have moral relevance, and we have to choose one over the other. And part of this process of recognizing conflicts of conscience is that we may feel like we're acting against our informed moral judgment. what we believe to be morally wrong or unjustified. And doing so compromises our sense of integrity, that sense of wholeness, that sense of being able to be in alignment with our convictions and our values and maybe some of our own internalized norms. So being sort of put off balance, and that feeling of being out of alignment with what matters most to us. So I want to give you just a little bit of what we know in the literature. This isn't a very well-studied area of our practice, but there are a couple of studies that I think are worth mentioning. This one, back in 1993, in the Decisions Near the End of Life, which was a multi-site national study of healthcare professionals, and it asked the question about whether or not clinicians felt they'd acted against their conscience in treating terminally ill or dying people. 47% of all respondents said they acted against their conscience in providing care for the terminally ill. 70% of house officers and 50% of nurses. In a later study involving pediatric providers, this was again a study of 7 sites across the country, 781 pediatric clinicians that involved attendings, fellows and nurses at the front lines. And the question they were asked was, at times I've acted against my conscience in providing treatment to children in my care. Similar results, more than half house officers, almost half of critical care nurses, smaller numbers of critical care attendings and in pediatric oncology, both attendings and nurses reported fewer instances. And we might wonder about what accounts for that. In a more recent study, this was a international study where on one single day, clinicians in ICUs across Europe were asked about their experiences of acting in a manner contrary to their personal and professional values, and about a third of them reported doing so. And the most common reason cited was providing treatment perceived to be excessive or overly aggressive. So this gives us a sense of the magnitude of these issues, something we need to explore more fully, but it's important to think about how do we respond to these situations that actually challenge or threaten our integrity. Well, first, we might think about conscientious compromise. Are there ways that we can make compromises that don't actually violate our sense of integrity? Sometimes the response is to give voice to it, to bring the issue forward and to have dialogue and to try to discern more carefully what the facts are and what the values might be at stake for various people. Another response is conscientious exemption and refusal, and we're going to talk about that in a little bit. Another one might be responsible whistleblowing, and for situations that are repeated and chronic that are not able to be resolved for people, sometimes the best thing is for people to leave the environment. So just to orient our definition of conscience-based objections, I'm using the definition from the American Thoracic Society. And they define conscience-based objections as objections to providing or disclosing information about legal, professionally accepted, and otherwise available medical services based on a clinician's judgment that to do what is requested would be morally wrong. So we're going to use that definition today for our conversation together. And I'm going to turn it over now to Dr. Althaus to present a case that I think illustrates some of these issues.
Good afternoon. All right, my first test question. Can everyone in the back hear me? Raise a hand if I can see a back row person. Perfect. So I selected this case. One, it's obviously I'm very familiar with in my specialty, but also because it's one that people can very easily understand why a conscientious objection would arise. So on an average day, Mrs. S calls at the office. She's 17 weeks pregnant and feels a pop and a gush of fluid. You have her go to the hospital, you do your exams, and you confirm without a doubt that she has broken her water. Now, as most of you probably already know, we simply do not have the medical technology to help a newborn survive if they're under 24 weeks. So she clearly has broken her water in a situation where there's nothing we can do if the baby is delivered. So the prognosis for the pregnancy is discouraging because that breaking of the water interferes with the development. There is a substantial risk to her health. So following a discussion, the patient and the physician, you decide you're going to induce labor. You put in the orders, but the nurse assigned to take care of her learns that the fetus's heart is still beating and refuses to take care of the patient because they don't believe in abortion. So this is an example of one of the reasons that people do have a conscientious objection. And I like to sort things into what people might object to and then why they have the objection. So the first category for what people object to is that sometimes there's an objection to a specific procedure or a specific treatment. Abortion is probably the one we most easily understand. The debate in the United States regarding euthanasia or physician-assisted suicide is another one where you'll hear people talking about a procedure or treatment that they don't believe in. And that idea of assisting at the end of life ranges from active assistance to physician-assisted suicide, but also goes into the realm of withdrawing support when you feel it should continue. So there's a spectrum of what it is that they are objecting to. And the why behind that is, while many people have it expressed as part of their faith, which we'll hear more about later, sometimes there is also a philosophical objection. So your first idea is there's a treatment or procedure they're simply opposed to. The second concept is there is a treatment that they don't oppose the treatment, but that they feel it's violating certain principles to an excessive degree. So most of the principles people think about are not harming the patient, doing something that will actually benefit or beneficence, autonomy, respecting what the patient or the family speaking on behalf of the patient wants, and then justice as well. So some people, for example, might have an objection to a treatment plan that they can see is causing substantial suffering and pain to the patient, and that it's being done day after day after day, and they really object to this amount of suffering being caused. Another example of a treatment plan is the idea of providing treatment in what they consider is ineffective or futile is the more common expression. The idea of continuing to do ventilation or aggressive treatments when the prognosis really has no hope for improvement. And usually that has to do not necessarily philosophy or faith-based, but people have assigned different values to those principles. So some people will say, I'm really respecting the patient's decision, and therefore I'm not going to a certain treatment plan. Whereas others would say, but you're really making the patient hurt and providing no benefit. So it's more an assignment of where they feel most of the value in those principles are placed. The final one is not one that we think of often, and fortunately it does not come up often, but sometimes we have a conscientious objection to a policy or a plan that puts the medical staff in danger that that staff person finds to be excessive or has a danger to others. The most common example for that, for those of you who may or may not be old enough, when HIV was first discovered, these conversations came up because at that time there was no cure, no treatment, we weren't too sure how it was transmitted, and many people expressed the concern with whether or not they should have to expose themselves to a potentially lethal virus. The conversations came up again with Ebola. And again, there's no treatment and no cure. But most of the time, these policies have to do with whether or not they're putting somebody else in danger. So for example, if you take the idea of Ebola, some people would say, I have no problems as a medical professional putting my life at risk. That is what I have signed up to do. But I'm the single mother of 3 children. And if I contract this and die, nobody is there to support and provide for those children, and I have to take that person into consideration. A similar concern is a healthcare worker who happens to be pregnant. And as we deal with the ongoing Zika crisis, and if we have a patient with Zika, a pregnant healthcare worker has to think about these things. And usually the why part of why they object has to do with their concern, not necessarily for their own health, but the collateral damage to a third party who did not sign up for those similar risks. So those are the three very broad categories that we find that people will raise conscientious objections to. And it helps for us to understand, well, what it is they're objecting to, and perhaps the reason why it has become such a concern to them. Great, thank you.
I'm going to ask Gail now to talk a little bit about her context of issues where claims of conscience may come up in the critical care area, and to also speak about how she manages this as a nurse manager.
Great. So I really,
Hold it for a second.
I'll do one better. There you go.
okay, let's try this again. I actually didn't know what Jane was going to say, but honestly, I'll tell you that so much of what I thought about were the actual same issues that occurred in real life in our unit. So let me just take a step back and let you all know that when people apply for jobs here at the hospital, it's important to know that there is a disclosure that's actually made at the time of application. And the disclosure form is actually attached to the policy that I think Cindy is going to discuss sooner than later at the end of our conversation. And what's important is to know that as a manager, I certainly look to see if there are any disclosures made to make sure that we can accommodate the disclosure. For instance, I recall after being in my role for 10 years, there was one person that did actually explain that it would be difficult for her to participate in any procedure that was similar to what we talked about, and that would be an abortion situation. I felt as though we could accommodate that claim and proceeded to hire this employee. I know it is the policy of the hospital to review any disclosure and to really make accommodations for whatever work environment may fit that employee. So disclosure is important from the get-go, and we have a process around that. Secondly, I think when we look at a clinical environment and we start to interview people, the next step that I think is important is to be open and honest about what happens in our units. And in my unit, in the neurocritical care unit, we have found that it's important to really discuss, under the framework of resilience, what does it take to be a nurse in an environment like this? How do you take care of yourself? And from that, we talk about why. In our unit, we come upon situations where patients meet brain death criteria. We may simply note that we will work through that process, and also we work through the process of organ donation, and that happens quite a bit in the NCCU. It's also important to understand when there is time to move into a situation where we withdraw care on patients. So we find that it's important to discuss this with all staff. Even during interview, this is what we do. We actually have quite a few deaths in our unit, and we want to be sure that people are aware of that. I'm not sure I ever really thought about this as disclosure with the idea of somebody having a conscientious objection to any of this, but it's probably just a natural process that we found to make sure people do understand that this is what the job is really all about. And if they found that they couldn't do this, well, we would want to help them find a place where they could very comfortably take care of patients without having any sense of objection to what may be happening in our care. The other thing that I do like to mention for our staff is that it's important to note that we actually do find that our families are often even in a state of crisis. And what does it take to actually manage that? Because with that comes discussions that frontline staff actually have with our families. I mean, sometimes the nurse is the first person to actually hear from families when there's a conflict within the family. And they might need to bring that forward where they're hearing multiple sides and multiple opinions about how families feel about various situations that might create conflict within that family that we need to bring forward as well. I think it's important to really discuss the fact that I don't have staff in our unit ever talking about really conscientious objection to things, because that's not common language for us. But what really is common language is when staff express distress over what's happening. Just a Distress over a plan of care. Why are we doing what we're doing? Where are we going? What is the ultimate goal of the care that we're providing? And importantly, we often move to that place where if this is persistent and we feel as though as a nursing group, and I mean that might be our clinical technicians or anybody on the staff that might express this concern, what do we do and how do we start to discuss it in a much more open format? People who are providing direct care, I think, have a different experience that's important to talk about. Pain and suffering, just as you mentioned, really sometimes is the driver when you're providing direct patient care. Providing physical care to a patient. We've had situations where we think we're moving towards the end of life, we're not there, family's not there. But you're providing things like skin care to a patient's body, where skin is just sloughing, and you're providing dressing changes that are really painful for patients. And again, these are the issues that do cause us to bring those concerns forward, and what do we do with them, and how do we do it? Patients that have infections that seem to be continuous, that we're not successfully treating, and again, that conflict that does arise. What do we do? The first thing that I think that we are open to is staff will often say things like, we need to talk more about where are we going. I don't know that I can continue taking care of the patient under these conditions. I'm finding it too difficult to come in every day and do this. And usually that means that others are thinking the same thing. And what I know we need to do is sit down with staff and start to get that dialogue started. What's happening? Why is it happening? Review the medical record with the staff. Make sure we gather our facts. Certainly then to sit down with our medical team and make sure that everybody understands what dilemmas we are facing. And if there is moral distress, to help put language out there for staff to really hold on to be able to say, yes, I am having the sense of moral distress, and it's typically not just one person, it's usually a larger number of people. We have been more successful over time when we are sitting as a team discussing what are our next steps, and that typically includes who are our resources, who do we reach out to, where do we get help for the staff, whether it's the nursing staff, the medical staff, anybody. And we have actually expanded so much that call for help. And it looks like this, really. I tried to make a list in sort of order. First, we will make sure that all of our attendings that are in our unit are well aware of the issues that are being brought forward. Secondly, there's always an attending of record. It might be, in our situation, a neurologist or a neurosurgeon. Have we totally engaged with them about where we are in the ICU environment? And sometimes that's a piece that seems to be missing. That person's just not in the know as we need them to be. We certainly know that partnering with palliative care and being able to discuss with our palliative care team their involvement. We have also found that working with infectious diseases, with our oncology partners, bringing them to the table with us, because some of the staff may have taken care of, say, an oncology patient for a very, very long time, and we might not be engaging enough with them when they are in our particular critical care environment. Our administrators who want to be involved and tell us, don't take such a long time to consult with us, we're here to help you. And also the ethics committee. And I find that trying to be proactive and act early on rather than waiting, maybe days, weeks, can really provoke even greater moral distress in staff. And looking to where those resources are and really acting upon the next step in getting action for the staff so that people understand that we can come to a decision about what needs to be done in a much fuller and more respectful way, given the fact that we often need the resources of others to really help us make the right decision. So just to discuss like, what do we do typically and how we do it, we thought I could just summarize in our particular intensive care units the steps that we typically take.
Thank you, Gail. I'm going to turn to Carol now. We have, I think, at times not completely understood what these kinds of situations might mean to our patients and families. So I've asked Carol to speak a little bit about that. Carol has been a member of our ethics committee for many, many years. She is the mother of a young woman with cystic fibrosis, and so she has had quite a lot of experience in the acute care center. Carol?
Hi. So I've thought a lot about this over the years. Obviously, I started coming to Hopkins as the mother of a very sick child when she was 5 months old. So I've seen different stages of care over my years, and also being involved with the Ethics Service and the Patient Safety Committee, have really thought a lot about some of these issues. So they're sort of near and dear to my heart. I think one of the things that we need to think about is what happens when patients come through the door and what that expectation looks like to them. And I think a lot of times when you come through the door, you're establishing a trust relationship because it's fraught with all kinds of anxieties and all kinds of unknowns. So you're putting yourself in the hands of people that you believe are there to help you through whatever illness you or your child is looking at, or traumatic, anything that you might need healthcare attention for. So I think at that point, you want to feel like you're in a position of a trustful relationship, number one, that communication is going to happen in an honest and real way. And over time, I have really felt that this concept of establishing goals of care early on can go a long way to understanding where you're headed and what these different options are, and establishing those goals of care, as sort of silly as it might seem, because it might seem obvious to you because you do it all the time, it's not as obvious to the patient, or to their family. So establishing those goals of care, even though they might become very general to start with, and then get more specific as things progress, because very, very important. Unfortunately, we don't have a system that is easy to understand as far as healthcare delivery. There's a real continuity of care issue. So I think, who's coming on, who's going off, having those discussions, and knowing that that care is going to transition smoothly is really, really important. And I think that in that context, and you start to think about at what point somebody on the healthcare team might raise this sort of conscientious objection, and how that's going to feel to the patient or to the family of the patient. And I think that if you have ongoing discussions, it's much easier to broach that in a way that makes sense. But if it's not carefully done, I think the reaction of the patient or their family can be one of abandonment, lack of trust, or loss of trust. I think that it puts people on the defensive. It's like, okay, well, if you're moral, what does that make me? So if we have an honest difference of establishment of goals of care or difference of belief structures, then if you feel that somebody's abandoning you because of their personal belief and their moral, sort of distaste for what you are asking them to do, then it automatically puts you in a position as a patient of saying, well, am I immoral? Is there something are you judging me in a way that doesn't allow for good care to continue? So I think that whole continuity of care thing and the abandonment is really important at that point. So establishing goals of care, I think also, there are times when if the nurse, if it is replaced easily, if the doctor's saying, okay, I need to end this pregnancy at 17 weeks because there's no viability for this fetus, and the nurse is saying, I can't do it, can you get a nurse in there that is equally as talented, equally as able to do that procedure without interrupting the continuity of care and that sense of trust and abandonment for the patient? So I think it's really important that communication that goes on over the time that the patient is here. When you're a frequent flyer, when you're coming in, you have a chronic condition, you're coming in, And there are times when you're handed off to different teams, the outpatient team, the inpatient team, the pediatrics team to the adult team. Again, having open and honest discussions will allow, I think, an environment in which conscientious objection can be raised and minimize that sense of ostracizing the patient or family, or that mistrust, distrust kind of environment. I think that there are all kinds of situations that make these things come up. I think avoiding words that are flashpoint words like palliative care or hospice might not be as good as comfort care. You know, I think that caring business is really important. I think that patients do expect for your personal beliefs not to interfere with their care to the extent that they can. So, I think that's it.
Thank you, Carol, for orienting us around the people we serve. Ty is going to talk a little bit about the sort of spiritual and religious aspects of claims of conscience.
Yes, good afternoon. So I want to start with an assumption that everyone in this room has done something that is out of alignment with your faith. Can we agree to that? I see some heads nodding. Yeah? Maybe. Well, the sense of that, so if you have a spirituality, and sometimes, as we know, there's a growing number of people that are spiritual and not religious, and those of us that are more religious have certain codes that we need to live by. They're very important, and I think you recount your daily life or your weekly life. You may look back in your history and say, gosh, I remember when I did that. And then how did that feel? And how did that leave you as you start to think on that and try to restore back into an alignment place with your faith, whatever that faith is. Those are the places I think we're trying to talk about when you're at work and you're asked to do something that might throw you out of alignment with your faith. And I think that people that are going to be falling into the category of the more religious or very religious are really less worried about this life and more concerned about the life to come. And so in that scenario, what's most important is that they stay in alignment during their life. They make the choices that they can in order to stay in that good place, whether it's with God or whomever their higher power is, that alignment is intact. And that's a very personal thing. That's not something that is, actually it's something that could be studied maybe one day. Can everybody hear me? All right. So the question is, what happens then spiritually to us when we find places of conflict? And again, I think it is a very personal question. It's a personal reflection. And to the point that was made earlier, I would assume that once it bubbles up to the point where you're telling your manager or you're telling someone else, you've thought a lot about it already. And so I think that's an important point to make. And the other point to make is the question, do we take enough stock of how we feel our faith or our spirituality impacts our work? And to the extent, do we also get to know the other, the people that we're working with, to really understand where their point of reference is and what things actually mean? Because we all know that not everything is in alignment with each other. Our faith traditions are actually quite different. I also wanted to divert just for a moment here to talk a little bit about chaplaincy, because chaplains also find themselves in these predicaments. And I'll speak about one instance and then another. The first one's a little bit more benign, which is around prayer. So what happens to the chaplain when they're asked to pray for something that they personally don't believe in? It actually comes up quite often. The patient that wants to win the lottery, for example. Yes, I've had that question. Can you pray for the lottery? Well, that doesn't jive with my faith, but how do I sort of manage that? And for chaplains that are asked other questions that are more intensely challenging points. How do you manage those clinically? So you really are supporting the patient. Hopefully you're getting to know the patient and what actually is underneath some of those questions. But the other scenario, which is more of a lightning rod across, I think, the country in chaplaincy, is around infant baptism. And how we offer infant baptism, because there's lots of variations to that. And certainly in this hospital and other hospitals where there's a chaplain training program, you have diversity of students. So how do you accommodate the non-Christian chaplain student who's on call and is asked to perform a baptism late at night for a baby that has just been born and may not survive much longer? So those are more of those scenarios where you do need to have some contingency plans in place, knowing who's on call and how they will manage that. In fact, I was telling a story yesterday about there's another hospital in DC that is being, there's some concerns about its student policy around how they manage that. Their policy really is pretty forthcoming. You will provide a baptism. And there was some concern about putting students in that predicament. I think that's all I'm going to say. Thank you.
So I want to thank our panel. We wanted to create the landscape of how these issues around claims of conscience might come up for us. And before we open it up to discussion, I want to go back to the definition that we started with. And I think there are a couple of things we might want to highlight here. Objections to providing or disclosing information about legal, professionally accepted, and otherwise available medical services based on a clinician's judgment that deduce what is requested would be morally wrong. And I think part of what we want to distinguish here are some of these factors around what is legal, what is professionally accepted, and I think in my experience, the professionally accepted is where the gray area comes in, and often there's not consensus about what is professionally appropriate in this particular situation, and that the therapy is otherwise available. So in thinking about that, I'd like to open it up to our audience here for comments or questions, to see what's on your mind, and then we'll spend a little bit of time talking a little bit more about some of our resources here. Comments? Questions? Mark?
Particularly in the situations where there may be moral distress and people feeling uncomfortable about a particular plan for the patient. If enough people are distressed, but you still need to render care, do you have any suggestions about how do you accommodate it when you accommodate the objection when maybe multiple people are concerned?
So that's a great question, and I think the way that it plays out is that people express that they're tired, they're exhausted more than they are not able to actually do the work for a moral reason. And I think in that situation, we'll work with the individual and say, take a break. I think to your point, what's really important is that the right person is taking care of that patient to help us all move forward, our families, our patients, our staff. And I think our staff is large enough that we can actually do that. And I think that's really important because of the article when I was reading about when does this become difficult to be able to maintain or to be able to safely operationalize our unit, our care, that it could become a problem. So I think by providing that break early on, and for those that feel exhausted, making sure we have enough resources to do that, and then making sure that we can figure out where we're going and what we're doing to help reduce the moral distress that staff is feeling. And I think we've been actually very successful with that, probably because that dialogue has started very early on. It's what Ty said, if you come to the manager or to my senior nurses and you've already started to talk about it, you've thought about it probably for quite some time. So that's how we deal with it. I don't know if anybody else would like to offer any more to that.
We're down to 2 mics, so we'll just swap the microphones out. The other component that you were bringing up, I think, is what happens if you get such a critical mass of people objecting to the treatment plan that you now have a scarce resource. And you only have 2 nurses willing to work, or you only have 1 attending willing to do it, and this person's going to be here. And an important thing is that for some people, that conscientious objection isn't an absolute, that they may say to themselves, I absolutely object, but what I object more to is abandoning a patient. And if you're telling me there's absolutely no one else to take care of this patient until 7 a.m. tomorrow morning, I might be willing to step in and do that duty because I am committed to that principle as well. So conscientious objection isn't always an absolute, and it always has to be placed within the context.
Okay, so, and then I think one thing I want to say about this is that when thinking about conscientious objection, you have to also think about the consequences of that objection. And again, how does it result in the care for the patient? But is your moral distress, does it trump the distress or the results of that pulling back from the patient? Does that trump the patient's position? So I think sometimes we have moral distress about something, but because we're healthcare providers, because we're in this environment, because we've agreed to act in a position of service, we make a conscious decision to go ahead and give service, even though it's not what we personally believe in. And whatever distress you're feeling, perhaps the patient's distress would be much worse, or the result of that objection, and not giving service would be much worse, a loss of life or some other negative result. So communicating to a patient an objection might not always be the best thing. I think you sound like you have it really well handled on your floor, and you get into it early on. But I think it's thinking about the result is important.
So yesterday, the Supreme Court decided not to rule on the Zubik v. Burwell case where the Sisters of Mercy, as an employer, object to having to sign a waiver about not providing contraception coverage. So I'm wondering how much of a difference, it sort of fits exactly with the clause up there, except that they're not clinicians. How much of a difference does it make if the person having a conscience-based objection, where healthcare is the issue, is whether they're a clinician or an employer of a different sort?
Well, I'm not sure I can answer the question fully. I would suspect if there are folks objecting who are non-clinicians, I would probably first have to have more information on what their particular code of ethics are. Certainly nurses have nursing code of ethics, as do physicians, and I don't know under what ethical precepts or codes other non-clinician people operate when they are making healthcare decisions. Do you have a specific thought or person or situation?
Well, this is the case where nuns have a religious-based objection to providing contraception.
Yeah, so this is one of the things, I get lots of controversies in my field, but while we talk about abortion as a big lightning rod, in fact something as straightforward as contraception is as well. And in many hospitals or Catholic hospitals, providing artificial contraception is against their tenets of faith. So it does become a larger issue. How does a facility stay true to its ethics and its precepts and provide care, and in the same context, recognizing that patients come in with different codes as well. And it's not a situation that has been resolved by any means. And it plays out in hospitals, it plays out in pharmacies, where some pharmacists will say, I will not provide the contraception or abortifacient. Some physicians say, I won't provide it, and I'm not going to tell you who will. I won't even refer you, because I might as well just hand it to you myself. And there is a huge continuum on a lot of these issues that is being played out across the country. And having a Supreme Court that can split 4-4 on any decision at the moment does not guide the situation well.
Other questions? What's on your mind? I'm looking at you, and what's the headline? How many of you have been in a situation where you yourself have felt that your conscience was being violated, or at least challenged or threatened, and weren't sure what to do with that? Yes?
My area is the neonatal.
I speak into the,
My area is the neonatal ICU. And I think a situation that comes up fairly frequently is not so much, nurses certainly don't want to abandon the babies. For example, ones with many problems, and they are at a situation where it really is futile to carry on. And this happens over months. So everybody will take care of that baby and be very invested. But it's difficult. You have parents who want to continue care no matter what, and then they don't visit, hardly ever. And so the distress is having to take care of this baby who's, everybody knows will die at some point, but then it goes on for months and months. And when the parents do come in, I think they are approached with different options and told that this option, these are painful things that are happening, but you end up still just carry on, do everything, so there's no withdrawal of care. They'll still get resuscitated each time they try to die by themselves. And that is a huge moral distress, which definitely goes across the team from attendings to nurses. But throughout, everybody will take care of that baby, and they'll be distressed about it. So then you have a huge group with moral distress, but really they're taking care of the baby regardless. Any thoughts?
so I think, the case you described of in the neonatal unit, if we go back to the consensus about what the sort of professional framework is for that care, is there consensus about what is the appropriate treatment under those circumstances? How much uncertainty is there? And how do we, as I think Gail pointed out, how do we begin to have dialogue among ourselves around the distress and what the nature of that distress is? Are there things that need to be clarified in terms of the facts, in terms of the values that are at stake, in terms of the process? And I think all of us as individuals have to continue to reflect on our own values and how they are how they influence the way that we see the situations that we are encountering. And I think also Carol's point, how do we think of our role as a professional? And I think what you're pointing out is sometimes what happens is we do put our professional values aside, the moral distress is there, and we do continue to provide care at a cost. And so part of the question here is how can we begin to raise these questions for dialogue sooner
Are there some interventions and some strategies that we could use to perhaps address the different values that are at stake, depending on your role, how patients and families are seeing the situation? And can we work toward creating more of a culture where it is appropriate and welcomed when these questions are brought up? One of the things we did want to highlight here, and I suspect that many people in this room are unaware that we actually have a policy, it's an HR policy, about how requests not to participate in situations that threaten or violate professional's conscience is handled. And that process, I think, is an important one. Gail pointed to part of that, which is if an individual is coming to work in a particular setting and we have an obligation to disclose the kinds of care that will be provided and the kinds of ethical issues that may occur, there's also a requirement of the person who is applying for that job to share and openly disclose what they may or may not feel that they can participate in. And part of that is to create a good match of integrity on both sides so that we're clear about what's required and how those values may align or not. The second one is when people feel that they are being asked to do something that violates their conscience. It is important, again, to disclose that and to have open dialogue about those boundaries. How can we accommodate as a unit, as an institution, people's requests not to participate? And Gail, I think, also highlighted that a lot of times people will rise to the occasion, and many times what we've had is volunteer situations where those conflicts are known. Individuals have had an opportunity to opt out, given appropriate resources to not interrupt or abandon care for the patient, and that then we allow people to voluntarily choose to participate. So some of it is how do we begin to bring these issues up more fully in our treatment teams, among ourselves. And I think really importantly, Carol's talking about how do we communicate our differences in values with our patients and families. I'm wondering if anybody has found some successful ways for how you've managed these situations that you might want to share for the benefit of the rest of our community. Anyone? Something? Yes, Lynn?
This isn't an answer to your question, Cinda. Sorry, I don't have any brilliant ideas on that. I just wanted to bring up another issue that I've come across, and that's a twist on the definition that you had up there about non-disclosing information and cultural issues. And I've struggled with this, and I can think of a specific example of a Chinese family. The son, adult son, was stage 4 of lung cancer. He was really getting close to death. We wanted to have a discussion with him about code status and what would happen next. The father, I remember him sobbing and begging us not to have that conversation because in his culture, that would take away all hope and the son would surely die. And so it was a struggle. You know, our belief, autonomy is so strong and the patient has a right to know. And their culture and that clash, it was really difficult.
What did you decide to do?
There was also an adult daughter, and we had a family meeting, and against the father's wishes, we had the discussion with the son. The daughter was the POA for healthcare, and that was really hard.
So that really dovetails into a question I wanted to ask all of you, and that is, how do you react as a professional caregiver and healthcare provider to the conscientious objection of the patient to a treatment or to a particular communication process like that. I can remember going to the bioethics course at Georgetown, and we were having these small discussions, and there was a doctor there from Cameroon, and he said, you know, we would never, ever go to a family and say to them, we have to talk to your loved one and tell them that they're dying. So it just would not be accepted, would not be done. And that was the responsibility of the family. And that there were certain communications that would be made through the family's behaviors, that the patient would know that this was, you know, sort of ritualistic sort of things and traditional things, but it would never be spoken. And so I think there are so many times when we think about conscientious objections from the healthcare provider's standpoint in delivering or not delivering certain treatments, but how do we react and what's our process when we really believe that it should be done, but there's a conscientious objection on the side of the patient?
Who wants to respond to that?
I think that's what cultural diversity meets this. And I guess I've seen it in the nursery, where we've had families come in from Africa, mothers with infants who have very bad prognoses, that they've come to Hopkins because it's Hopkins. And we found that we're not sure what they expected, but the staff were kind of like, well, is there going to be surgery? Are we going to give vitamin K? Or which page are we on? And they're, you know, be unclear. And people would be uncomfortable trying to figure out how to have the conversation with the family. And I think that the ethical piece that we all know is new, but what's been really stressed is cultural diversity, for us to be very aware of that. And I found that sometimes there is a conflict because we care for people who we have different cultural things. And I don't know if there really is an answer. I think it's open communication, trying to figure out expectations. But I've found that happens, especially when we have families from Africa we care for.
Just to add to that, we have patients that are usually, they have no capacity to make the decision on their own right, but the family is making the decision. And we had a recent situation that you described where we had a family meeting, and it was conducted mainly by our fellow, who is really a fellow in training, but probably did one of the most incredible jobs I have ever seen in dealing with a situation such as you described, what do we do next? And what he did that was so great was he started the family meeting by saying, we are here to give you information. We're going to give you all of the information we think you need to know what to do next. Because we're at a crossroads, and whatever your decision is, we support. He started off by saying that. And then the medical information that the team thought was necessary was provided, and that included looking at brain scans, looking at lab results, things like that. Then also discussing what's next. Are there any other options left? The family needed some more time after that to be able to talk together, work together. Came back to us and said, if we wanted to not proceed on, but provide comfort care using the exact word that you described, what would that look like? And they actually needed information to be able to make that decision. And in the end result was that we moved to comfort care once family members came, gathered, and even provided support to the family that this was the right thing to do. After we did remove some of the therapies, the patient actually even lived for a number of days, maybe even until a week or so later. But the family was at peace. And I think that was the goal of what we had hoped for. If that family had said, pursue even longer, I do think that our team would have done that because we knew that there were a few more things that maybe we could do. However, they did not see where it would actually take us in regards to any form of meaningful recovery for her. So I just wanted to use that as an example of incredible dialogue that occurred with a young fellow, with the support of some others in the room with him, but he did a great job not putting the pressure on anybody. And I think it's that openness that you were describing, that families need the information to be able to make the right decision. And I just thought I'd use that as an example to others to say that this is really possible.
We're close to our time here, but I did want to come back to the original point about the NICU and the baby situation that you raised, is that it really points to our need to pay attention to what's happening for us and our needs for support. I think healthcare workers in general are notorious for not taking good care of themselves. And what are those identifiers? And if you have a particular situation, a particular patient on your unit, and everyone knows that when whoever's taking care of that patient is going to have a struggle, that there's probably some system that can be put in place so that there's some additional support and people can talk about it. And that may be the only positive thing that comes out of having one particular patient on a unit that everyone dreads taking care of, is that you can rally around that and actually pay attention a little bit better. But to find someone on the unit that you can talk to. Find the chaplain. Find the social worker, find the person that can confide in and offer some support, especially if you're trying to make meaning out of what you're doing. I think those things are very deep inside of us, and it's important to pay attention to.
So I wanted to end with a little bit of summary. We've been talking about this question of the boundaries of conscientious, exemption, and refusal, and I think it's important to highlight some of the points that we've heard here. First of all, the right to refuse or request exemption is not absolute. And this is where our personal values and our professional values sometimes are in tension. But certainly as we have all signed up for the roles that we have also accepted the prioritization of our patients above our own interests. That doesn't mean, however, that our interests don't count, but it is important, and I think we've heard this a couple of times, that non-abandonment of our patients is one of the criteria that we use in determining whether or not we can accommodate requests not to participate. We have to ensure patient safety in the process, and one of the options is, I think Carol kind of alluded to it, transfer to an equally qualified provider. So if there's someone else for whom this is not a conflict of their conscience, then in a way that's the best scenario for creating integrity of everyone on a team. Second of all, requests, I think we have to be clear about requests not to participate versus unbridled claims of refusal. And what that means is we've got to be clear on the basis on which we are asking not to participate. Is it truly a conscience violation? Is it something that I'm exhausted in taking care of this patient, or I don't particularly like the behaviors or the decisions of the patient or the family? So we want to be very careful to cordon off these claims of conscience and how they then relate to our sense of integrity. A respectful exercise of conscientious objection. I think sometimes what happens is when we don't address these issues, our behaviors can come across in ways that patients and families detect as being somewhat disrespectful or dismissive. And so it's important for us to recognize that these things are occurring so that we can address them in a way that allows us to continue to provide compassionate quality care. Certainly, we need to have a process, a due process, that is fair and respectful. And I would refer you to the American Thoracic Society consensus document of the 4 critical care societies on a process for how to address clinician claims of conscience. And it points out the need for balance, the balance in terms of patient and family interests and also the interests of clinicians, so that we can have a parallel, respectful process to make sure all the interests are heard and respected. And then to think about, as a community, what does reasonable accommodation look like? What promises are we making to each other? How can we be inclusive of our diversity of values among us? and among our patients, and what kind of accommodation might we be willing to commit to create an environment of ethical practice. And then the final piece is the organizational structures and policies. We have a code of ethics here in this institution. If you haven't read it, you might want to take a look at it. It's probably really interesting. And also we have our own professional codes of ethics, so nursing and medicine and other disciplines. We do have a policy here for conscientious exemption and refusal. It's an HR policy. Many people don't know about it. You might want to take a look at that as well. Certainly our ethics consultation service here is available to help in these cases, and we would really appreciate the opportunity to participate before things have kind of really gone down the tubes, to try to help identify what the nature of those conflicts might be and how we could work together to create solutions that would be supportive of both patients and families and the team. Looking for cases that cause distress or create claims of conscience, and looking at how we create a more robust ethics infrastructure here in our own institution. So I want to thank our panel for sharing their insights on this, and I want to thank all of you for being here, and we look forward to continuing this dialogue with you, and look forward to getting your feedback about how we might be able to support you more fully.